what we're going to do this morning is hemodynamic assessments. And again, as I said before, it allows us to measure velocities in chambers and blood vessels, pressures in chambers and blood vessels, gradient across valves and shunts, stroke volume and cardiac output. And this is very important to people who take care of critical patients. You can calculate cardiac output, and it's fair. Once it's done properly, it's very accurate. You can do valve areas, regurgitant volume and fraction. So if the patient has, say, mitral regurgitation, one of the assessment for severity is regurgitant volume and regurgitant fraction. You can do that. Regurgitant orifice area, that is another method to evaluate the severity of your regurgitant lesion. So, you can use hemodynamics. So you're gonna use the information that we gave you before to do your hemodynamic assessment. And one of the information you need is your Bernoulli equation. So you're going to need your Bernoulli equation to... Okay, so one of the equations that you're going to need is your Bernoulli equation. And the Bernoulli equation allow you to calculate gradients between 2 points. It assumes a closed circuit, okay? And the flow, another important point you're gonna have to grasp is if you have a closed circuit, say you have a pipe, if the pipe is not leaking, the flow at all the points along the point is the pipe is going to be the same. If you have a closed circuit, the flow at all the different points in that circuit is going to be the same unless there's a leak. Okay? The pressures and velocity is going to vary if you have obstruction at various points in that system. Pressure and velocity will vary, but the flow is going to be the same unless there's a leak. When we talk about the gradient, it is a pressure difference, okay? And if you don't have a pump, you usually have your pressure higher up in the circuit is going to be greater than the pressure lower down in the circuit, unless you have a pump. So when we talk about the Bernoulli equation, okay, let us describe what we're talking about. So we're talking about a flow in a closed circuit. So if we consider this a closed circuit, no leaks, and you have a constriction or an obstruction at some point in this circuit, pressure 1, pressure 2, if you have a flow in this direction, flow from left to right, the pressure at point 1 is going to be greater than pressure at point 2, okay? Unless you have a leak in the system, okay? But there's no leak in the system. The pressure here is going to be greater than pressure there if you have flow in this direction, okay? Okay, so what is going to vary in addition to the pressure being different, the velocity is going to be different. So the velocity at this point, point 1, and velocity at point 2 is going to be different. The flow at all points in this circuit is going to be the same. Just take a couple seconds to appreciate that. Once you have a closed circuit, the flow is going to be the same. Flow is going to be the same. So the Bernoulli equation states that the gradient, right? So if you have a flow in this direction, the gradient, which is the pressure difference between point 1 and point 2, okay? Again, the pressure in point the pressure at point 1 is going to be greater than the pressure at point 2. So the gradient is a difference in pressure. In rough terms, it is equal to the convection acceleration plus the flow acceleration plus what we call the viscous friction. And we can represent each of these things by an equation. So the convective acceleration is equal to half rho into the velocity at point 2 squared minus the velocity at point 1 squared. Okay, so this is the convective acceleration. Okay, so the convective acceleration is equal to half rho, and rho is the density. V2 is the velocity at the obstruction. V1 is the velocity at point 1. Okay, so this is the convective acceleration. Then the flow acceleration, okay, is represented by this. You need the velocity, the average velocity, and the time, okay, and distance, okay, and then the viscous friction is represented by the resistance and the velocity. So this is the formula, the Bernoulli equation formula. This is the full formula for Bernoulli equation, which describes a gradient between 2 points. Okay. Again, pressure at P1 is pressure at location 1, P2 pressure at location 2. Rho is the mass density of the blood. V1 velocity at location 1, and V2 velocity at location 2. In clinical practice, we're going to make a few assumptions, okay? And you need to know these assumptions because they, if these assumptions are not carried out, you can't use the modified Bernoulli equation, as we call it. You cannot use the modified Bernoulli equation unless, these assumptions are met. And so again, in clinical setting, we ignore the flow acceleration and the viscous friction. So in clinical practice, we assume that the viscosity of blood is 1, okay? And so we ignore this, the viscous friction and the flow acceleration, okay, in clinical practice. So all we use is the convective acceleration, which is equal to half rho into the velocity squared at point 2 minus the velocity squared at point 1. Okay, so we're left with this. And if we assume that these are negligible numbers for blood, we're left with this. And then what we know for blood, half of rho, that's the mass density of blood, half rho is equal to 4. So when we plug that into the equation, the gradient, which is the point difference, the pressure difference at point 1 and point 2, is equal to 4 square of the velocity at point 2 minus the square velocity at point 1. But in clinical practice, we usually deal with a very narrow, a very short segment of obstruction. So we ignore V1 because the segment that is obstructed is usually very short. So we ignore V1. So what we're left with, the modified Bernoulli equation is 4V squared, and you have to remember this. Okay, the gradient across any obstruction or any shunt is equal to 4V squared, where V is the velocity, okay, across whatever it is. So we use this formula to calculate the gradient across structures, valves, shunts, obstruction, you name it. One of the practical application of this modified Bernoulli equation, so the modified Bernoulli equation states that gradient is equal to 4v squared, whereas v is the velocity. Now, if we can use this equation to calculate gradient, then we can also calculate absolute pressure. Just think about it. When you have, let's look at tricuspid regurgitation. When you have tricuspid regurgitation, blood is flowing from the right ventricle across the tricuspid valve into the right atrium. So tricuspid regurgitation, blood is flowing in the opposite direction to which it normally flows. And this occurs in systole. So tricuspid regurgitation is a systolic phenomenon where blood moves from the RV across the tricuspid valve into the right atrium. So therefore, the pressure in the RV have to be greater than the pressure in the RA for the flow to occur. You're only going to have flow in a particular direction unless the pressure difference is there. If you have a pump, then that's different, and you don't have any mechanical pump or electrical pump in the heart. So what we're saying is that the RV systolic pressure, all right, so the RV systolic pressure, so say RV systolic pressure minus the RA systolic pressure is equal to the gradient, right? That makes sense because the pressure difference is the gradient. The pressure difference is the gradient. And because blood is flowing from the RV across the tricuspid valve into the right atrium, the pressure in the RV is greater because blood is flowing in the opposite direction. So the pressure difference, systolic, because it's a systolic phenomenon, the RV systolic pressure minus the RA systolic pressure is equal to the gradient. We can get, so the modified Bernoulli equation tells us that the gradient is equal to the 4v squared. So when we look at the flow across the tricuspid valve in systole, when we look at tricuspid regurgitation, we get an envelope. We get an envelope, a systolic envelope, and we can get the velocity of that envelope. So what modified Bernoulli equation states is that the gradient then is 4v squared, looking at your TR velocity, tricuspid regurgitation velocity. So if we rearrange this equation, then your RV systolic pressure and just the RV systolic pressure is equal to the gradient plus the RA pressure. Plus the RA pressure. Okay, simple rearranging the equation. So the RV systolic pressure is a very important number to us who do clinical work. It's very important because the RV systolic pressure is usually the same as your pulmonary artery systolic pressure unless you have an obstruction at the right ventricular flow tract. The RV systolic pressure is usually the same thing as your pulmonary artery systolic pressure unless you have an obstruction at the right ventricular flow tract. So if you can calculate this RV systolic pressure, you automatically know your PA systolic pressure, and you will know if there's an obstruction at the right ventricular flow tract. So this is a valid situation in 99% of your patients. So again, the modified Bernoulli equation states that the gradient is equal to 4v squared. The velocity we're talking about is your TR velocity, the peak TR velocity. So we get the velocity when we do our Doppler, and if we square that, multiply it by 4, we get the gradient, and then all we have to do is add the right atrial pressure, and we get the RV systolic pressure. So again, the modified Bernoulli equation, gradient is equal to 4v squared. We look at the gradient across the tricuspid valve. Okay, so a gradient or pressure difference, we talk about the RV systolic pressure minus the right atrial systolic pressure. So that's right atrial pressure. So if you rearrange your equation, the RV systolic pressure is equal to the gradient plus your right atrial systolic pressure. Okay? All right. So that is a very important that's very, very important in clinical medicine, in echo, because one of the things that you're going to do in echo, once the patient have TR, and up to 80 to 90% of your normal patients going to have some amount of TR. 80 to 90% of your normal patients will have tricuspid regurgitation. So you can give a right ventricular systolic pressure or your pulmonary artery systolic pressure in up to 90% of your patients. Okay, which is a very important number because clinically it's very important. And again, when we talk about diastolic function and dysfunction, we use the TR velocity, which is a surrogate of the pressure. All right, so again, the right ventricular systolic pressure is usually the same thing as your pulmonary artery systolic pressure, unless there's an obstruction at the right ventricular flow tract. So usually the same number. So with the modified Bernoulli equation, when we talk about the velocity, it is your tricuspid regurgitation velocity. Okay. And so when you do your echo, okay, your two-dimensional echo is on top. This is the short axis at the level of the aorta. Okay. Your cursor is across the tricuspid valve. This represents your probe or your transducer. There's tricuspid regurgitation. Okay, so Doppler. Okay. There's a flow going from the right ventricle across the tricuspid valve into the right atrium. That is why it's below the baseline. Okay, it's a systolic flow. Remember your ECG is on top. Okay, systole is from the onset of your QRS to the end of the T wave. So you have this constant systolic flow, which is your tricuspid regurgitation. The peak velocity is the velocity we're talking about. That's your tricuspid regurgitation velocity. If you square this velocity, multiply it by 4, you get the gradient across your tricuspid valve. The gradient. Gradient is just a pressure difference, which is your right ventricular systolic pressure minus a right atrial systolic pressure. And once you rearrange your equation, then your right ventricular systolic pressure is equal to the gradient plus the right atrial pressure. We're not going to talk about right atrial pressure today because it's a topic on it by itself. When we do right heart, then we'll go into how you assess right atrial pressure in detail. Okay? So all you need to know is that your RV systolic pressure is equal to the gradient plus the right atrial pressure. And you need to know how to get the gradient. 4v squared. which is your peak TR velocity. All right. So you know that when we talk about PA pressures, when we talk about most pressures in the cardiac chamber, we have a systolic pressure, we have a diastolic pressure. So what about the PA diastolic pressure? Okay, we can do that too using hemodynamic principles. So if you stick to the basic concept, so let's see how we could get our PA diastolic pressure. All right, so the pulmonary artery diastolic pressure. If you look at your pulmonary trunk, look at the pulmonary trunk, you know that the normal blood flow is from the right ventricular outflow tract across the pulmonic valve and into the pulmonary trunk. If you have pulmonic insufficiency or pulmonary regurgitation, blood is going to flow from the pulmonary trunk across the pulmonic valve into the right ventricular flow tract. That is what pulmonary regurgitation is, or pulmonic insufficiency. Okay? Blood is going to flow from the pulmonary trunk across the pulmonic valve into the right ventricular flow tract. That is pulmonary regurgitation. You can only get pulmonary regurgitation if the pressure in the pulmonary trunk is greater than the pressure in the right ventricular flow tract. You can, I mean, water doesn't flow uphill unless you have a pump. So for you to get pulmonary regurgitation, the pressure in the pulmonary trunk is going to be greater than the pressure in the right ventricular flow tract in diastole, because pulmonic insufficiency occurs in diastole. Pulmonary regurgitation is a diastolic phenomenon. So what we're saying is that at the end of diastole, the pressure in the pulmonary trunk is greater than the pressure in the RV. So that's the diastolic RV pressure then. So the gradient is equal to the pulmonary artery end diastolic pressure minus the RV end diastolic pressure, because blood is flowing from the pulmonary trunk into the right ventricle. You cannot get that cannot occur unless the pressure in the pulmonary trunk is greater than the pressure in the RV in diastole. That's the only way that can occur. So the pressure difference is what we call the gradient. Pressure difference is the gradient. And we have a graphical representation of that, the PI, the pulmonary insufficiency envelope. So you put your Doppler across the pulmonic valve. So your Doppler across the pulmonic valve, and you get a diastolic envelope. Okay? The velocity of that diastolic envelope, if you square it and you multiply it by 4, that is the gradient across the pulmonic trunk and the RV. That is the gradient. So again, the gradient is equal to the diastolic pressure in the PA minus the diastolic pressure in the RV. If you rearrange this equation, you'll get the pulmonary artery end diastolic pressure. Okay? Pulmonary artery end diastolic pressure. The gradient you can get using the modified Bernoulli principle or equation, because once you get the velocity of your PI, you square it, you multiply it by 4, you get the gradient. Your right ventricular end diastolic pressure is the same thing as your RA pressure. So again, we have a separate lecture to talk about RA pressures. Okay? So once you know your gradient, you can calculate your PA end diastolic pressure. All right? You need to have pulmonary insufficiency to do that. But those of you who do echoes, hands-on echoes, know that up to 70, 80% of your patients gonna have some amount of pulmonary insufficiency. Okay? So the gradient is equal to 4V squared. Your right ventricular end diastolic pressure is the same thing as your right atrial pressure. We have a separate lecture to go over that. So when you do your echo, when you actually do your echo, your two-dimensional echo is on top. Your transducer is right there. This is short axis at the level of the aorta. Your cursor is across the pulmonic valve. Sample volume is at the pulmonic valve. And when you have pulmonary insufficiency, you're going to get the envelope looking like this. This is what PI looks like. This is what PI looks like. Okay? And that is why you need to actually do echoes to appreciate this thing. It's going to be extremely difficult for you to do echo well from a theoretical standpoint unless you actually do it. As a matter of fact, you cannot do echo well unless you have hands-on experience. Okay? So this is your pulmonic insufficiency. You have your early velocity and your late velocity. Okay? This is your end diastolic velocity, and this is your early velocity. Okay? So if your ECG is on top, okay, pulmonic insufficiency or pulmonary regurgitation is a diastolic phenomenon from the end of the T wave to the QRS. It's a diastolic phenomenon. The velocity we're talking about is your end diastolic velocity. The end diastolic velocity. So A is your early velocity and B is your end diastolic velocity. Okay? So, and it's simple after that. You get your end diastolic velocity, you square it, you multiply it by 4, that's your gradient. You add the right atrial pressure to it, and that is your PA end diastolic pressure. Okay. So these are just a definition for the terms we use. Okay. All right. So you can use echo to accurately get your PA systolic and your PA end diastolic pressure. Again, echo Doppler is angle dependent. So once you have to do this in multiple windows because you want to get your ultrasound beam as parallel to your blood flow as possible because of the cosine of your angle theta. Cosine of theta. Cosine of 0 is 1. Cosine of 90 is 0. Okay? So you want to get your ultrasound beam as parallel to blood flow as possible. So if it's done properly, it's extremely accurate. If it's not done properly, it's a disaster because you're going to make faulty assessment for the patient and you will end up hurting the patient. So that is why you need to know how to do echo properly. If you can't do it properly, you're going to use the theoretical knowledge and you're going to use your faulty analysis and you're going to try and apply it to the patient and then you'll hurt the patient. So if the echo is not done properly, do not use it. It's extremely important that the echo is done properly. It's extremely important that you know what you're doing, not by just putting the probe and getting a number. That's dangerous. You have to know what you're doing because of these, the angle. Okay, so just getting a number is not adequate. Okay, you have to know the windows that you need to use. Okay, and then use the windows to get the situation where the ultrasound beam is as parallel to blood flow as possible. All right. So left atrial pressure, we talk about diastolic dysfunction and left atrial pressures and stuff like that. So it would be good to calculate left atrial pressure, especially if you have a critical patient, you have a patient in ICU who is not doing very well and you want to see what's going on. I mean, you can calculate left atrial pressure. Again, the echo have to be done properly. So just getting a number, if you're not sure about the number, if you can't do echoes, do not use the numbers that you get because you will hurt the patient. So what you do, if it's done properly, then once you have mitral regurgitation, if you have mitral regurgitation, you can calculate your left atrial pressure because mitral regurgitation is a systolic phenomenon where you have blood flowing from the LV across the mitral valve into the left atrium in systole. It is blood flowing from the LV across the mitral valve into the left atrium in systole. Okay? So the gradient is your LV systolic pressure minus the left atrial systolic pressure. That's the gradient. Again, if you look at your MR peak velocity, you square it, you multiply by 4, then this is what you get. Since you want left atrial pressure, you just rearrange your equation, you take it to the left, okay? You take the gradient to the right. So your left atrial pressure is equal to the left ventricular systolic pressure minus the gradient. And again, I would say the gradient is 4v squared, which v is your MR peak velocity. Your left ventricular systolic pressure, is the same thing as your systolic blood pressure, unless there's an obstruction at the left ventricular flow tract. Again, your LV systolic pressure is the same thing as your systolic blood pressure unless there's an obstruction at the left ventricular flow tract. So that is why when your patient comes to the echo lab, you have at the initiation of your echo study, you have to do vital signs on the patient. You have to do blood pressure. You have to do the heart rate. Okay? Because we're saying that the systolic blood pressure at the time when you're doing your echo is the same thing as the LV systolic pressure unless there is obstruction at the left ventricular flow tract. So you can calculate your left atrial pressure and you can see if the left atrial pressure is normal, if it's very low or it's elevated. Okay, so this V is your mitral regurgitation velocity. LVSP is your systolic blood pressure if there is no obstruction across left ventricular flow tract. And so practical case. So two-dimensional echo is on top. This is across. This is a two-chamber view. So the cursor is across the mitral valve, and sample volume is at the mitral valve. Your cursor is right there. Okay, so blood is flowing from the LV across the mitral valve into the left atrium. That is why it's below the baseline. Okay, it's a systolic phenomenon because you can see your ECG is on top. Systole is from the beginning of your QRS to the end of the T wave. So it's, in systole, you're getting these Doppler envelopes. Okay, the peak velocity is once you put your marker there, you can see the computer gives you the peak velocity. It is 5.54. And those of you who do physics know why it's minus, okay? Flow downwards is negative, flow upwards is positive. So that's right. But anyway, all you need is the absolute value, which is 5.54. This is the peak velocity. So you square it, you multiply it by 4, and that gives you the gradient between the LV and the left atrium. You want the left atrial pressure. So your left atrial pressure is your LV systolic pressure minus the gradient. So LV systolic pressure is just your systolic blood pressure. Systolic blood pressure, okay? Unless there's an obstruction there. And your left atrial pressure is when you do Swan scans or you use any other method to get your pulmonary capillary wedge pressure, it is a surrogate of your left atrial pressure. Okay, that is what you're measuring. So if you can use echo, and you can use echo once it's done properly, you can get a rough estimate of your pulmonary capillary wedge pressure. As a matter of fact, you get a direct left atrial pressure. It has to be done properly because it's a Doppler technique which is angle dependent. You have to do it from multiple windows in order for you to get the maximum velocity. All right. So that is how you do left atrial pressure. And left atrial pressure is tremendously important. Okay. Now, again, when we do pressures, we talk about systolic and diastolic pressure. So we can also get the left ventricular end diastolic pressure, because if you remember, when someone develops heart failure, one of the first things that's gonna increase is your left ventricular end diastolic pressure, because for you to develop heart failure, usually that means the LV is not functioning properly. And if the LV is not functioning properly, the pressure is going to go up. Whether you have diastolic heart failure or systolic heart failure, the hallmark of heart failure, usually, unless you have mitral stenosis, is an elevation in your left ventricular end diastolic pressure. Because for whatever reason, your LV is not working properly. And if the LV is not working properly, the first thing that's going to happen, the pressure is going to go up. So that's a hallmark. So how can you calculate your left ventricular end diastolic pressure? Simple. The same principle that we use for your pulmonary artery diastolic pressure, the same principle. So let's look at it again. So if you have aortic insufficiency, if you have aortic regurgitation, what that's telling us is that you have flow of blood from the aorta across the aortic valve into the LV. Aortic insufficiency means you're going to have flow of blood from the aorta across the aortic valve into the LV in diastole. Okay? The only way you can have blood flowing from the aorta across the aortic valve into the LV is if the pressure in the aorta in diastole is greater than the pressure in the LV in diastole, and that pressure difference is what we call the gradient. Okay? Again, the gradient from the modified Bernoulli principle or equation is equal to 4v squared. So if we get the velocity of that pi, we square it, we multiply it by 4, then that's a gradient. And then once we rearrange our equation, then we can get our LV end diastolic pressure. So again, for you to get aortic insufficiency or aortic regurgitation, the diastolic pressure in the aorta diastolic pressure in the aorta have to be greater than the diastolic pressure in the LV. That pressure difference is what we call the gradient. So blood is now flowing from the aorta across the aortic valve into the LV. This is the gradient. This is what we don't know. We don't know the left ventricular end diastolic pressure. But if we rearrange our equation, the left ventricular end diastolic pressure is equal to the aortic diastolic pressure minus the gradient. The gradient is equal to 4V squared. Okay? When you do your blood pressure, when the patient walks into the echo lab, your diastolic blood pressure is equal to your aortic diastolic pressure. Unless nothing. Your aortic blood pressure, your blood pressure, your diastolic blood pressure is equal to the aortic diastolic pressure. It's the same number. Okay? So you use your diastolic blood pressure, and you're going to subtract from that the gradient. So you get your Doppler envelope across the aortic valve, and you use the end diastolic velocity. You square it, multiply it by 4. You subtract it from the diastolic blood pressure, and that is your left ventricular end diastolic pressure. Okay, so again, your velocity is the velocity at the end of your AI spectral display, and your aortic diastolic pressure is the diastolic blood pressure. So this is what it looks like. So your two-dimensional echo is on top. Okay, your cursor is right there. This is an apical three-chamber view. So whatever view gonna give you the maximum velocity, that's the view you're gonna use. Okay, cursor is across the aortic valve. The sample volume is just right above the aortic valve, and you get this diastolic envelope. Diastolic envelope. Again, diastole is from the end of the T wave to the QRS, so you get a diastolic envelope, and you get so it slopes. It slopes downward, and this is your end diastolic velocity. End diastolic velocity. So the gradient across the aortic valve is equal to 4V squared. Okay? So you square your velocity, multiply by 4. And that gradient is equal to your diastolic blood pressure minus your left ventricular end diastolic pressure. So your left ventricular end diastolic pressure is equal to your diastolic blood pressure minus the gradient. And you can calculate your left ventricular end diastolic pressure. Okay? So we're going to stop here. You need to fully understand what we have done, because it has practical implication.